All right, let's move on to the long-acting reversible contraceptives, otherwise abbreviated as LARCs. So these include the progestogen-only injections, subdermal implants, and IUDs. But before we go into the specific sections, let's first take a look at exactly what long-acting reversible contraception means. So the definition is that these methods require administration less than one time per cycle. So where the pills were needed to be taken every single day of your cycle, these only need to be taken maybe once every 3 cycles, as in some of the injections, or even once every few years, as with some of the other methods. Then there are some benefits to using these forms of contraception, and the first is that studies have found that there are superior continuation rates with LARCs as opposed to the hormonal contraceptions we spoke about earlier. They're also proven to be more cost-effective despite the initial high cost. So we're talking about long-term efficacy. The only one that seems to be more cost-effective is sterilization, but that only becomes more cost-effective after 15 years. So let's talk about each of the different methods. The first one we're going to do is the progestogen-only injectables. So as with the other two contraceptions, we've got our little character over here who's going to be representing the progestogen-only injections, and we've got all our different key characteristics. So let's get started. I think we'll come back to Our Lady, but let's go on to first do an overview. So firstly, the injection is highly effective and it's widely used. The reason why is because it can easily be given straight after a pregnancy or even a TOP, and it's administered by staff, so there's no ineffective way of administering it. And as I said, it's highly effective. It's also suitable for most people because it doesn't have estrogen, so it doesn't have all of those contraindications that using estrogen would entail. Then, as you know, it's administered via a deep intramuscular injection. Okay, so there are two types of progestogen-only injections. The first is the DMPA. This is short for depomedroxyprogesterone acetate, or as it's more commonly known, Depo-Provera. And then you've got the NETEN, which is norethisternate. So those are much easier to say as the DMPA and the NETEN. Okay, so with the Depo-Provera, it has to be administered 12 weekly. So this is the equivalent of 3 monthly. Whereas with this one, it has to be administered 8 weekly, which is 2 monthly. So the Depo-Provera is often preferred because it's also cheaper and it has less menstrual changes associated with it. In addition to the fact that you only need an injection once every 3 months as opposed to 2. So remember that not all contraceptives are effective immediately, and this is one such contraceptive. So if taken within the first 7 days of your cycle, so within the first 7 days of the beginning of your period, then it provides you with immediate protection. Remember the combined oral contraceptive was in the first 5 days, this one's the first 7 days. And if it's taken after day 7 of your cycle, then you need to use a backup method for up to 7 days. Yes, okay, then that's all I have to say about that. Let's move on to some contraindications. So, as you may have seen here, this is a familiar mnemonic that we spoke about in the previous videos, and it originally was POPs can't stop that pregnancy, but I realized that a lot of the contraindications for the methods that use progestogens are actually quite similar, and this makes sense because they all contain progestogens. So I've changed it to progestogens can't stop that pregnancy. Okay, and as with the POP, the contraindications for the progestogen injection are acute porphyria, current breast cancer, severe cardiovascular disease, we'll skip this one for now, and perimenopausal. So the one thing is that enzyme-inducing drugs are not contraindicated in the progestogen-only injection. And it has been seen that, so remember with inducing drugs, they speed up the metabolism of other drugs. But in this case, it has been shown that you don't need to shorten the interval between injections on the progestogen only injection, because the levels actually maintain quite well throughout the full 3 or the 2 months, depending on which method you're using. So basically, it's not a contraindication. So then we still have this word DAT, so I just changed it to one of the other ones. It's a bit of a stretch, but delay for 6 weeks in breastfeeding women. So it's not contraindicated to use in breastfeeding women, but you should delay it for 6 weeks. Okay, then let's move on to some of the side effects. So before discussing side effects, now it might be a little bit useful to talk about our character. So this over here is Izzy for injectables, and she is a ballerina and she wants to go on contraception, but she has heard that some of the contraceptive methods can get rid of your period, and she's heard that the injection is one such example. And as you can see, she is wearing this beautiful white tutu, and in the upcoming show, this is her outfit. And as you can imagine, she does not want to randomly have a period and have an emergency with this very white outfit. So that's her. So that brings us to the side effects. The first is that so all the side effects are, you can have irregular, prolonged bleeding or spotting and heavy menstrual bleeding, or on the opposite end of the scale, you can have amenorrhea. And then another significant side effect is weight gain, and this is due to an increased appetite. Then there are also some other minor side effects. So let's start with these two. With irregular, prolonged bleeding or spotting and heavy menstrual bleeding, it is quite a common side effect in the use of injections, but the important thing to reassure your patient is that it will decrease over time. So if we go to the management, if the bleeding is spotting or just light irregular bleeding, then as I said, you should just reassure them that it's not harmful, it's common in the first few months, and it will decrease over time. The other thing that you must definitely do is exclude other causes, because although it's common, it might be masking some other kind of genital tract pathology. Then you can also treat this by prescribing 7 days of low-dose contraception, combined oral contraception, and this is in an attempt to try and regulate the cycle. You can also use NSAIDs, especially if combined oral contraception is contraindicated, and this should also help reduce the bleeding and help with some of the pain that might be associated. Then you're going to go on to some, if the bleeding is more heavy, prolonged, or more frequent, so 2 times as much or 2 times as long as usual, then the first thing that you must do is exclude pathology. If you've done that, then you can reassure her that it's probably not harmful and it should diminish over time. But on the other hand, may require attention, especially if your patient is anemic, or has become anemic due to all the loss of blood. In this case, you'd want to treat with iron supplementation, and you'd also want to treat with 21 days of high-dose combined oral contraception, followed by 7 days of the placebo, so 1 pack of the COC. You can actually do this once or for 2 cycles in an attempt to control the bleeding and regulate the cycle better. If combined oral contraception is contraindicated, you can use NSAIDs, or you can use tranexamic acid, which, as you know, is used in the immediate treatment of heavy menstrual bleeding. Okay, so the next side effect is going to be amenorrhea, and as opposed to this side effect, which should decrease over time, this one actually increases with time, the incidence of it. So much so that actually 80% of users are amenorrheic within the 2nd year. And although this may be seen as a side effect for some women, in others, like Izzy, our ballerina, it is often a sought after benefit to using this form of contraception. But if your patient is worried about it and they come to you complaining about it, then you can explain to them that it is normal, it's not harmful, and that it should, not that it should decrease, but that it's just normal and it's not harmful. Then the next side effect is weight gain. Now remember I said over here that the reason why this is a side effect is because it has been known to increase your appetite more so than anything else. And by that I mean that it's not the actual medication that's causing you to gain weight, it's the increased appetite that might cause you to gain weight. And then the reason why we also have Izzy is because she's a ballerina and we tell her about this, but she knows that she is already on a strict diet and does plenty of exercise, so this is not going to be a problem for her. Then, oh, where are we? Okay, then we also have some minor side effects. So all the ones that aren't underlined are the same as the previous two forms of contraception, and the ones that kind of correlate with symptoms of pregnancy. So remember, if they present with these, you must first exclude pregnancy. Then in addition to these, you have acne, which can be worsened or exacerbated by the injection. You can also have bloating and abdominal pain. And they think that the abdominal pain is caused by the enlarged ovaries, which are no longer ovulating. So the last side effect, which is not really a side effect, but it's something important to remember when considering this method of contraception, is that there is a delay in fertility after stopping the administration of the injection. But the important thing to assure your patient is that there's no permanent damage to fertility. So with the NETEN injection, there's about a 4-month delay in return to fertility. With the DMPA, there's a 6-month delay. So this is just an average. It may vary from patient to patient. Okay, then lastly, let's move on to what you do if you're late to get your injection. So in the case of the Depo-Provera and the NETEN, when you get your initial injection, you'll be given a date for re-injection exactly 12 weeks later in the case of Depo-Provera and exactly 8 weeks later in the case of the NETEN injection. Now, because life happens and because of issues related to access and getting there on time, there is a grace period that is accounted for when coming up with these dates. So in the case of Depo-Provera, you can be up to 4 weeks late on your re-injection appointment, and you'll still have good coverage against pregnancy. In this case, you have a 2-week grace period. And it makes sense that this is a bit less because this injection requires slightly more frequent injections. So you'll have a 2-week grace period after your initial re-injection date where you still will have good coverage. Now, it's important to convey this to your patient because if they are for some reason unable to come in during that grace period, then they need to start using alternate forms of contraception or abstaining from penetrative sex. So when your patient comes in and they are more than 4 weeks late on their injection date in the case of Depo-Provera or more than 2 weeks late in the case of the NETEN, then you can give her next injection provided that you're reasonably certain that they're not pregnant. So what this means is that they're reasonably certain that they haven't had unprotected sex since their grace period expired. And then if you're not sure, then the question of an existing pregnancy comes into play. So what you do is you don't give the re-injection straight away, but you advise them to use a backup method for the next 3 weeks, so either condoms or the progestogen only pill, and then you tell them to come back again after the 3 weeks so that you can check whether they're pregnant with a pregnancy test, and if they're not, then you can start again on the injections, and if they are, you can take it from there with discussing management options such as a termination of pregnancy. Then in some cases, your patient may not want to go onto a pill, or they're unable to use condoms, or for whatever reason they can't use an alternate form of contraception. So in that case, you can give the injection straight away, but it is important to convey to them that if there is an existing pregnancy, the injection won't abort that pregnancy, and it also won't harm that pregnancy. So they're going to need to still follow up within 3 weeks to assess for any possible pregnancy. Yeah, so that is progestogen-only injectables. In the next video, we'll be discussing subdermal progestogen implants.